Hi, everyone. So this is Dr. Isabelle Amigues, your friendly rheumatologist. So we had taken a little bit of a hiatus after the holidays during the month of January. Just to regroup, one, the practice of unabridged MD is growing. I'm really hoping to being able to add a physician to the practice. In the meantime, we have a pharmacist that has joined us. And so we have now 2 nurses, 1 pharmacist, 1 clinic manager. So it's a very exciting team, and I really do love them. And if you ever come on our Instagram account or other account, you can say hi to them. They are really behind the scene. And I just thought, I'm going to just do a very quick episode today, just to restart the process of getting back on track on offering you those weekly session of unabridged MD and Rheumatology 101. I would like you guys to tell me what you would like to discuss. Very often you are all asking very, very valid and very important questions. So we have talked in the past about why it's important to reach remission as soon as possible in rheumatoid arthritis. We've talked about different disease. So we've talked about gout, we've talked about pseudogout, I believe. We've talked about lupus, Sjogren, we've talked about RA, of course, ankylosing spondylitis, psoriatic arthritis. We've talked about how to diagnose them, how to treat them. And so then we've had some questions about how to treat enthesitis, right? Or what's the association between eyesight and rheumatologic disorders? So those were questions actually from the audience, which, were not on the top of my head because that's not something that we necessarily see all of the time. And we can absolutely talk about everything. I could talk about the association between interstitial lung disease and rheumatologic disorder, neurology and rheumatologic disorder. But yeah, I would really encourage you to put some comment under this video that will live on YouTube. Put comments and let me know what you would like to discuss. I'm certain most of you have rheumatologists, and I'm certain they are in the insurance-based model. And so they may not have the time to go over some educational piece with you. And I would love that to help you with that, because that is really one of my favorite things to do. I love rheumatology, and I really love teaching rheumatology to everyone. So use it. If you want, you can also share this with someone that you love that has some joint pain, or that you think have an inflammation, or that you think have a rheumatologic disorder, or maybe their family has a rheumatologic disorder. And same thing, ask them to subscribe to the YouTube video, of course, and also to ask me what they would want to discuss. And I think, this is really a symbiotic relationship where I'm here because you are here. We have more than 1,000 followers currently on the YouTube channel. So thank you so much for everyone that subscribes. So please, again, if you haven't, go to YouTube and Rheumatology 101 by Dr. Amigues, Amigues, and subscribe, because the more we subscribe, the more we reach people. And what's happening, and the reason it's so important to me, is that it takes a long time to train a rheumatologist. It took me 17 years. Of course, I did 2 trainings, one in France, one in the US. It was more clinical in France, more research-based in the US. So I did not really repeat anything, more added. But it takes at least, 10 to 11 to 12 years to train a rheumatologist. And what's happening is I don't necessarily have the time to go on social media, share about rheumatology disorder. And I think that that's my job. My work is to make sure that we are represented on social media. There are people who talk about rheumatology who are not rheumatologists. And to me, it is really important that you get information from an actual certified and trained rheumatologist. And that is my purpose on YouTube, on social media. So share this, ask people to subscribe so that it goes to more people that need it. Of course, the people that don't need it don't have to listen to or watch this, and I definitely do not want to oblige anyone. There are, however, people who will find rheumatology topics that are basically educated, and they are more cool, right? Because there may be like videos and all this, like, and and just more cool, and I'm more austere, like I'm more simple. But that's because what I'm sharing is basically 17 years of an experience as well of training. And so that is really, to me, that's important and that's valuable. And I hope you see that it is valuable. So without further ado, I think I'm going to just basically stop this here. And I'm just going to answer the question of SS11TGJ, which is how France approach is different or similar. That's such a cool such a cool question, and I can actually answer this here since this is not really rheumatologic. But I think in France we are much more clinical oriented. There is no insurances with an S, and so it's an insurance. And when you work in a hospital, because you're considered to be the sort of like the expert, and then you can kind of do whatever you think is appropriate for the patients. Whereas when you work in the US system, you have to convey to the insurance why they should approach and they should agree on paying for therapy. And so when you're working with insurance-based model, when you're working with an insurance here, you have to basically explain why this is FDA approved, or all of those things, like why you like they have to pay for this medication or that medication or that test or this test. Whereas again, in France, if you're a doctor, the vast majority of time you can just basically say, hey, I know, like, you do not get any benefit from putting a patient on a medication or sending a patient to a radiology test or any other testing. And so because of that, there's no conflict of interest. And because of that, that's another reason why you don't have to explain basically everything you do. That said, I would say that the vast majority of doctors really are here to help their patients. And so that's the goal. Like, the goal is to help a patient. Sometimes I understand why the insurance is asking us, for example, to, if you have rheumatoid arthritis, you want to try methotrexate. But there are other times where I'm like, the methotrexate is actually, not ideal for a patient that drinks and doesn't want to quit. And in this case, I've seen insurance basically refuse to give us another medication until we failed the methotrexate, which the patient never took because that was not safe for them. And so that's like the main difference to me between the approach in France and the approach in the US, is that we don't have to deal with the insurances system, but it's because it's a single payer, and then the training is very clinical. And in the US, I found that the training is very evidence-based medicine, which I think is actually really valuable. It's very research-oriented, which again is also extremely valuable. I think sometimes, like what I've seen from trainings, right, is that you're so into this evidence-based medicine. So evidence-based medicine means that you're going to offer only what has been proven to be efficient against placebo. And sometimes you're so into this that you forget that there are things that work and that may not have yet been proven to work or to be wrong. Or and for example, meditation took many years to show that it works, right? Now we know that it does work, for example, for inflammatory arthritis. But I think, so that's one of those things. And the clinical approach would be, for a patient, for example, where you don't really know what they have, like it looks like this, from an inch, like because of the way we're trained in the US, we may be like, well, I don't have a label for this condition. And so then you're like, throwing your hands in the air and be like, okay, I don't know how to treat you. And in France, it would be like the way I've been taught, at least. I'm sure everyone is different, but the way I've been taught was, what does this look like? And then you make it simple. This looks like this. And if this looks like this, then I'm going to try this treatment. Okay. And there are definitely people who do this. In the US, it's just, I thought that in France, that was much more common to do it like that. So yeah. And I see Miguel that joined us, Vinay Gupta, Maggie, Dr. Una, Colorado Skin, nurse practitioner has also joined. Thank you so much for joining us. Today is just really just a saying hi to everyone. And then I have Spadesman Jones, and you are asking about why it takes so long for biology to work and how to be patient during that period. It just takes time. It just takes time. It just, you have to realize, like, so I don't know if I should do a full, maybe I'll do a full video on that, but just so that, because you have started, Spacey and Jones, you have already started the medication and you're trying to be patient. I would say the immune system takes time in immunology, right? Like for rheumatologic condition, it takes time to cause the issues that you have, and that are the reason why you're on this biologic. And so it also takes time for the biologic to reverse that, right? So think of it, to make an antibody that's going to protect you against a viral infection, for example. It takes time. It takes about a month, if not 2 to 3 months, right, to make this antibody. It's exactly the same thing. If it makes a month to 3 months for your body to make an antibody that's going to protect you, it's also going to take that much time to get rid of the antibodies that's protecting you. It's going to, like, you know, but you have antibodies that potentially are deleterious to you or that are causing harm. And I'm saying this, like, it doesn't mean that you have an antibody. I'm just saying, like, just to give an example, right? It takes time to make it. It takes time to get it away, right? And so that's why this takes time. And what we usually do when we're adding a biologic is that we're adding it. We're not taking off. And the way I personally do it is that I'm doing an in-between. So basically, I add the biologic because I know that the biologic is not going to work right away, although sometimes it works really fast. And then once you're perfect, then we can back off from this other drug, right? And so that's what we're doing. We're backing off from the other that doesn't need to be there necessarily, and we can slowly take it off. But first, remission is the goal. So to be patient, make sure that you're on the previous one, unless you had side effects, of course. On the other one, you can take some NSAID if you can, and if it's allowed by your physician, ask them. Sometimes we have to use a little bit of prednisone, not my favorite drug, but sometimes, or maybe just one shot of Kenalog of steroids can help you, bridge that gap. Okay, so those are like some of the things. And then, okay, honestly, this is maybe one of my favorite things to do, is that every time you're giving yourself an injection or every time you're taking your pill, be in that mental space of this is working. Like, rheumatology is an incredible field where we can get our patients to remission. Again, remission is different than cured. We cannot cure our patient mostly, but we can put them in remission. And that's huge, because remission is no evidence of disease, none, nada, you're perfect. Okay? I mean, no one is perfect, but you know what I mean. From that you're perfect. Like, you are 99%. And so because of that, just like every time you're taking a pill, every time you're taking a medication, I'm pretty certain that the vast majority, when they do that, they're like, oh, why do I have to do this? I'm so upset. Well, no, change it. Change the narrative. I am so lucky that I get to do this myself. I am so lucky that I get to get this infusion in an infusion center. I am so lucky that scientists have actually worked on this medication and have brought us this. I have done this when I had my own cancer journey more than 5 years ago. I did this. I would imagine that whatever chemo I was getting was literally going where it needed to be. And I felt so much gratitude for science. so much gratitude for the doctors and so much gratitude for that medication and for my body to be willing to respond well to this drug. So do that. That allows you to be patient a little bit more, because I get it, right? Like you're like, hey, I don't see the result. Change the narrative to, I'm doing something that I am doing. I'm empowering myself. I'm empowered. I choose. And so that will really bring you a lot of good feelings, and that actually makes you feel better. And without you realizing, you're going to feel better in no time. Biologics are amazing. That they are the reason I became a rheumatologist, and they are the reason I can say we can go into remission in rheumatology. So that's really good. And then I got another question from Predator. What an interesting name. I love it. Why do I feel worse from methotrexate injection than with tablets? That's a really interesting question. So my first thought as a rheumatologist is to wonder if you're actually getting more methotrexate in the injection than in the tablets, because typically injections are actually better tolerated. They're annoying because you have to inject, but they're usually better tolerated. So just double check, look at it. Usually we say if it's 5 tablets, it's 0.5 milliliter. If it's 6 tablets, it's 0.6 milliliter. If it's 8 tablets, it's 0.8 milliliter. The tablets at 2.5 milligrams. Again, I'm not a rheumatologist. And you're saying that it's the same quantities. That is actually really odd, and I'm not completely sure, because that's usually not the case. Then that being said, if you're feeling worse with the injection, then maybe go back to the tablets if that is a possibility for you. And I always say split the dose. So you can take half in the morning and half at night, or half the night before and half in the morning, because that really can help. So yeah. And then Spaceman Jones, who said, I'm also wondering if biologic studies can be misleading. Most of them seem to show about 50% of people get 20% better from what I've seen. Okay, so you have to realize that when we're doing biologic studies, we are doing it against placebo. So that's no, not against placebo. Like most of the time, we're not doing it against placebo. Ideally, you would want them to be against placebo to really show the effect. The problem if you do against placebo is that you're taking away the ability to put a patient in remission. So you're not allowed ethically, and that makes total sense. Ethically, you cannot do a study on biologic against placebo, because the patient would be needs to be on something, right? So you cannot just say, I'm going to try biologics against nothing. What you can do is say, okay, I'm going to try, let's say it's RA study. So it's first methotrexate, and then you add a biologics versus something else. The problem, again, ethically, is that after 3 months, we know that patients have to be versus something else. It shouldn't be biologic against nothing and just methotrexate, because you're losing some time for those patients. So it's becoming more and more complex to do studies on biologics in this era, because we have so many drugs that are working, and you cannot have someone where they are not going to have anything. So it's just the design is getting more complex, and it's totally, it's doable, but it's more complex than that. And then when you're looking at biologic, you're more and more looking at non-naive biologic patients in studies. So meaning that those patients have had other biologics. And if they are on a new biologic, then that means that they did not respond to the first biologic. And so in vast majority, at least in my practice, the vast majority of patients really respond to their first biologic. So when you're looking at studies on those patients that did not respond to the first biologic, then you're actually really taking a subtype population that doesn't necessarily work, respond as well to biologics. So just remember that the studies, we know as rheumatologists how to read them, researchers, rheumatologists, right? We know how to read those studies. I don't know necessarily that everyone knows how to read those studies, and clearly you know how to read the studies, but make sure that you have all of the data. And I would say that was one of the things that I loved the most in the American system. We were talking about the difference between French and American system, medical system. I loved learning how to read studies, how to design studies, how to participate in studies. So yeah. And Predator, I cannot really answer medical questions so much, but you're asking, you know, after 6 months of treatment, what analysis should you do? It really depends on what you have, and it really depends on what your diagnosis is and so on. If you want, after, I'm going to end the stream right now, but you can ask, don't put medical information, but you could say, hey, you know, what do you think of rheumatoid arthritis and how should you follow rheumatoid arthritis? I can answer those questions, right? It cannot be a medical advice because I'm not your doctor. With that being said, thank you so much. This has been actually really awesome. I love that SS11TJG or GJ. I like France. Do you think you will go back to France to practice permanently? Guys, I'm in Colorado and I absolutely adore Colorado. Look, it's January. There's a beautiful sun. While I love France, I don't think that I'm ever going to practice in France because I just love Colorado so much. So you guys should come visit me in Colorado. Come if you're looking for a rheumatologist. I'm here. I'm still taking new patients. It's always a pleasure and an honor. And without any more, I'm going to leave this. If you have any, please, if you have more questions, please ask them, put them here. We'll always go back to this and we'll see how we can help. And your questions are really what can make those Rheumatology 101 live more interesting. So thank you so much for being here. If you like this, share it, go to YouTube, Rheumatology 101, and become a subscriber, because that's really how we grow this. And that's how we share good, valuable information to the world. Thank you so very much. And until next week, take care. Bye-bye.